My name is Javon Willis, and I love these thoughts.
Can you see?
My name is Javon Willis.
Domino.
No. Yeah, I'm about to eat. Yeah, I'm cute.
Talking my name like he's long gear.
Who y'all waiting on? Here y'all.
That's all I got left.
All right, so whenever you guys are ready.
Good. Yeah, 38-year-old female found her sitting on her porch of her house, complaining of a headache.
How you doing? Is it working? I don't see no chest right.
Oh, hang on, it might be. Yeah.
It's he's gonna got chest right.
She just got a headache.
She stubs her toe.
Let me get Emily out.
Are you talking about muscles?
No, I'm talking about yeah.
Oh. Well, right up here is the first intercostal space right here. I don't want you to put the pads on this one.
Oh, so
No,
no,
put the sticker. You could put
Yeah, don't actually.
the 4 leads.
okay. I don't put a glove here.
Open them. You know how these work?
Yeah.
Or you know how they on this one, you just snap in.
Tap those.
It does. So
Yeah, snow around.
right over the zipper, right upper. Same breathing, yeah.
So we're not actually doing it. Yeah, this is west for
Yes, you will. You do that the Morris?
What's that, bro?
I know people out there like just walk up to the patient, they already know what's wrong with the patient. Oh, you can do that?
Well, he's gonna say no.
No, really. I mean, it depends.
Oh, you don't want to be cocky.
No, I mean, sometimes I could get a good idea if they're diaphoretic, nauseous, great. So I paint a picture of a cardiac patient in my head. And probably 75% of the time I'm right on that. But
Same person. Oh, he run.
but I get right, and that's it. I mean, you just see it so much, you know.
I look at you. I already know you.
I know
You got Michigan sore.
That's something wrong too.
Ugly triangle. You know how I had the race triangle? You okay? You get
It's almost
This supposed to be?
No, I bet it should.
That rhino.
It's like
Rhino. No, it shows you get gas. White and pink right now.
disrespect pro thing right there.
Like I mean.
An 8.
A lot of these.
You got shot. You got COVID? I guess. Hey man, that's yeah, that's true.
He sniffs it when he gets home.
That's easy.
But it's easier, but it doesn't taste.
Yeah.
No, that's a lot.
No.
Oh, then smoker?
No, charcoal.
Charcoal.
You don't have that gas, you take that.
I don't have a gas taste. Man, you gotta have a murder button, right?
You that sausage.
When I cook them, I like put seasoning on there, so I don't taste like that. Yeah, so I don't taste like that smoky flavor.
It's breathing.
Okay, it's breathing.
Try it. Try it.
Never heard of that. Also, I would bet money that all the next nobody goes to.
Try it. You would try it. Oh, you want that money?
I would bet money.
How much?
All right, I'm gonna have my team do CPR.
I can go ahead and start showing my.
Oh, yeah? You got photos?
Somebody-
I probably do.
Pictures of that.
Probably do. Oh, you ready?
Yeah, we ready.
I'll feel the shit out of this. Dispatch to a 38-year-old female, find her sitting on her porch complaining about her.
Hey, how you doing today, man? I'm Recruit Hall. What seems to be the problem?
My head hurts so bad.
Your head hurt? What was you doing before your head started hurting, man?
Trying to get some lunch.
Trying to get lunch? Did you eat anything today?
Just pray.
What's my general impression? Was she pregnant or anything?
You find her laying on the floor with a headache, real bad headache on the porch.
She lay on the floor. I'm gonna consider CSPA on this patient. I'm gonna make sure she didn't fall and hurt her neck or anything like that. Okay. I'm gonna hook up onto a monitor. Get some vitals from her.
And you guys are welcome to use that other arm if you want to.
Oh, we can?
Yes, sir.
How close is it? What her pupils look like? Everything normal.
Oh, yeah, you don't have to. Though.
Her skin look.
Warm and flush.
She allergic to anything? She need medications?
Almost in the pro.
And last time she ate was when? What time is it right now?
127.
Let me get a blood glucose. She just she ain't got no meds. She got any fast pregnant history? Any medical history? Huh? High blood pressure. What's her blood pressure right now?
Yeah, 6 up on.
You guys gonna read it?
180 over 100.
180 over 100. And then we're gonna check the blood sugar.
94.
22 breaths a minute.
We're gonna put a pulse. Let's put a pulse.
Good math.
She's taking it some pills.
She allergic to luciferin. You said she allergic to luciferin, right?
She takes it.
She takes it. What's her temperature?
99.
The blood glucose was what? 90 what?
94.
94 is the blood glucose. What's the SPO2? The temperature was 99. What's her oxygen percentage?
Good, that's good.
Yeah, it's on.
Both sides, 94.
Can she sit up? Can I sit my patient up?
You can sit her up. Just sit up. Just hurts her head really bad when she sits her up.
It hurts her head real bad when she sits up.
Yeah, when she's trying to sit up. It hurts her head. It's a blinding thing.
How are the lights and everything inside?
She's outside of the pool.
Who's outside? Bring her
We're
inside.
gonna bring her inside.
Turn the lights off. Or dim them.
We're gonna sit her up and bring her inside to the house. I'm gonna hook up onto oxygen, nasal cannula. I'm gonna hook up on 4 liters a minute.
Hey.
Hmm?
Try to stay.
All right. Keep it on.
Can't run away from this. We never get away.
Someone else says it.
How bad is the pain?
It's a 10.
It's a 10.
It's the worst headache I've ever had.
You can call man control. Tell them all the vitals is good. Our blood pressure 180 over 100. See them do nitro. Why you can't ask that nitro? Yeah, just tell them their blood pressure is high. It's 180 over 100. But the rest of the vitals is good.
Squad forward to make control.
What curves either.
We have a 38-year-old female with a deep inside headaches. We have vitals for you. Blood pressure is 180 over 100.
All right, I'm gonna put my patient on the put on the 4 lead.
Respiration.
Actually 12 lead.
17. Her SpO2
Let's
level
find out about
is
blood
94. Blood glucose is at 94.
Tell them we put on a 12 lead right now.
98. We currently right now have a patient on a nasal 4 liters per minute. And we're also attaching a 12 lead right now at this moment. That's just to give you an update.
When I feel around her abdomen, is there anything that looks abnormal? Hey, somebody from long time. It was clear. Long sounds clear.
What is the treatment for a patient of hypertension?
Get the sample.
I got the, so laying down is better for you. Then is laying down better for you than sitting up?
No, I don't want to lay down.
We
She
are.
doesn't want to lay down now.
We don't sit her up. See when you sit her up, like mine.
When you sit me up slow.
Body more back control.
Okay.
Come and make it up.
Go ahead and position your patient with their head elevated, monitor their blood pressure, and go ahead and establish some IV access, please.
Clear on having the patient's head elevated, checking blood pressure.
Ask him why he wants to get IV.
Yeah, that's about. Making sure come in.
We just wanted to start it. They don't want to fluid enough.
For the IV, are we just establishing the IV or will we be administering any fluids at all? Just wanted to get know why.
Just go ahead and establish it. No fluid bolus or anything.
Clear on that, no fluid.
Wait, hold on. What will we administer to our needs? I mean, that's the situation.
This is just start with one establishing.
There's no medication.
Probably not it.
I'll do it at the hospital.
Yeah.
Okay. Oh, no, we gotta do it. We just don't think.
We'll just say you got your line right here.
The patient's still sitting up, we just gonna lay it down. We're gonna start an IV, so we don't actually have to do it.
You don't have to cycle back.
I'll make this patient a priority patient. We get another blood pressure with the patient sitting up.
Still 180.
Yeah, you can put that on there and get the pulse. So we put in the pulse out, so we get the pulse again. What's the pulse?
Also pulse ox.
The pulse. On the pulse ox, the pulse?
Yeah, pulse ox is at 98.
No, the pulse. The pulse 98.
This is still at 100.
The pulse at 100.
You got a yellow card. You need to get some transport going, especially call for transport.
Already did. I just told him that.
You'll tell me.
Yeah.
What floor dispatch?
You said if I were a patient.
Call him control and get an ALS truck here.
Are you guys gonna require a LS or a BLS?
ALS.
We'll be requiring an ALS unit, right?
10-4.
How far away are we from Grady? How far are we from Grady?
You're 12 to 15 minutes out from Grady. And they were just asking, do you want to send you an ALS or BLS unit? So y'all aren't a transport unit.
I'm gonna keep monitoring my patient. What did the 12 lead say?
Oh, dude.
Yeah.
Y'all do it?
Yeah, you got to.
So what you have to do? Okay. All right.
38 and female. It's a female.
Give this second to fire it.
You can't read it.
Oh, no.
How's the breathing now that I got the down nasal cannula?
Should be, what is it, 98?
This 52 is 98.
He's still breathing at 22 times, or he's breathing a little slower?
It's about 18 now. Now you can tear it off if you want to. Okay, not gonna hurt.
Just tear it.
No,
All right, what does this mean?
I do want to.
what you're looking for up top, yep. And so if it was a STEMI or something, it would have star, it's the elevated MI, like this one right here. So it doesn't say that. So
How far is ALS?
don't know, sir.
Okay, thanks. How far?
What is the ETA on the ALS unit?
Or where's the BLS?
They're about 10 minutes out.
If they were further out, would you send a BLS? I mean, yeah, like if they were 30 minutes out, you had a BLS unit available.
Absolutely.
Yeah, because we're only like 10 minutes away from Grady, so yeah, so we're just gonna wait till ALS here. We're gonna change the reaccess our patient.
You tell them to come back in.
You guys can come back in.
Good call.
That's good.
No, they can drive. Yeah. Yeah, absolutely. Yeah, that's fine. Too. I just think I myself.
I ain't want to get an aspirin.
I hate to waste
blood pressure. Yeah, that's why you want to get. I know why you want me to get an aspirin. I'm like, I have blood pressure.
All right. So let's start with the scenario builders. Tell us what they where they were going, how presidents. I kind of missed that part.
They were going to
House and what they had.
and a 38-year-old female that found her. They were going to find her laying down on the porch complaining of severe headache.
Laying down. Just sitting down.
Hey, what you think, man?
You want my field impression or?
No, I'm sorry. What you think? I
About
had
the
to
scenario?
did. You could throw that in there too.
I honestly feel like we did good as a squad because I was speaking to them trying to figure out like what they may think it is. They came with so many different options. There was different ideas of what should be done, like what should be given to the patient. But I think that's good that people have their ideas. But that way you can look at the fighters and like, oh well, I feel like we shouldn't do that because of this. We shouldn't have because of that. And so I think we did good as like working together and people not like saying, no, you need to do this, you need to do that. I just think we all work together. But I do think I did. Well, I guess I messed up, but I said it, but I guess I said it to the wrong person. But with the whole transport unit, because I told him that I'm make the priority patient. I want ALS and route, but I didn't say it to med control. So,
He did that.
yeah, that one. But he said it after the yellow card was thrown.
Oh, I didn't. We never do the yellow.
Right.
Yeah.
It was like right before he called for the LSU national yellow card. Like,
Okay.
that's who's doing it.
Yeah. So besides that, I think we did good as a whole.
All right. Evaluation.
Yeah.
How'd they do?
I think they did really good. I think everyone on your team knew what they're supposed to be doing, delegated really well, and they helped you out when you needed it. Y'all were throwing ideas together. The only thing was the dispatch thing for the transport unit. The other reason I had done it is I was kind of waiting a second for you to do it because you have a 38-year-old female who has a blood pressure of 180 over 100. So you're in the hospital as soon as possible. But besides that, you all did a really good job. You were looking really well. So good job.
Yeah, you guys did good, man. And I think like what you said when your team was talking about options, like at one point somebody said that to give this patient nitro.
That was me.
And then you said, you guys talked it out respectfully, which was good. You guys worked out your answer. And then you got a call to get an IV line. And you were kind of questioning that based on
Good question.
based on your diagnostics. And then, it's good, dude. It's good stuff to be in the heat of the moment in front of your peers and to be able to discern and have questions and be able to work through them with your team. So that's good stuff.
I think, all looked like all the team members had a role and they played it. And they all had an opinion on what to break. So, yeah, other than transport.
Why I did communication and people scream.
All right. Med control.
Sounded pretty good on all clarify stuff that you weren't sure about, like IV access. Didn't really need anything.
So I agree with everybody. There was a question about nitro. So let's go over that. So what's nitro? What's it
All I
indicated
saw was 180.
Right.
And my mind went straight to it. I didn't even think about the fact that she's not even experiencing any chest pain.
for? That's okay.
That's what my head.
They
went straight
used to treat blood pressure kind of with nitro anyway, but they found out that if you lower a patient's blood pressure too fast, that's having a headache or neurological symptoms, sometimes it can increase their chances for a stroke. That's the reason why they don't like to use nitro for an emergency hypertensive crisis. Now, they'll use other drugs to bring it down slower.
But there's nothing else that we can give this person.
There is not, no. There is not. There's not a whole lot of paramedic can get. I don't know of anything a paramedic can get. The patient's going to require lab work. He's going to require some antihypertensive medicine, IV or pill inside the ER. Is that what you agree? Do you think it's hypertension?
That's what we think.
Okay, yeah, you're right.
So
It was.
If we would have gave aspirin, that would have made it worse, right? Because
It would not have made it worse. Remember, what does aspirin do? What do we give it?
anticoagulant.
Right. And so.
I know it's a blood thing. I didn't know if that would mess up the blood pressure.
Well, it's not really so much of a blood thinner. It just stops platelets from gathering on top of plaque or places where they shouldn't gather. So if you look at it like that, you can say it's a blood thinner because it separates them out. But I think what happens is we start looking at aspirin as a blood thinner. And most even, there's a lot of medical people too, though, that, and technically you call it that, but if you look at it like that, you miss the essence of what it really does to thin the blood. It's just reallocating the platelets to say, no, you guys are not going to gang up here. Y'all are going to move past this. But yeah. You would have hurt the situation, right? But you're not going to help it either. So it wouldn't be indicated for it. So here we go. So we're going to talk about hypertensive crisis for a second. How do we get here? How do we end up in a hypertensive crisis? What's the physiology behind that? No, not the symptoms. What's the physiology? What's going on? Right, that's part of it. What's going on inside the body? So vasoconstriction. What's that? Well, yeah. So what ends up happening is this. All right. So we end up having a disease process that affects the vessels. All right. So we already know we got the parasympathetic, which counteracts the sympathetic, right? What ends up happening here is the vessels become less pliable due to cholesterol. And instead of the cholesterol making that vessel really slick inside, really smooth and pliable, too much of it can make the vessel less pliable. And so when the message comes in to vasodilate, the vessel really doesn't vasodilate like it used to. It stays in more of a constricted mode, right? And so what can we do then? I mean, think about it like this. I mean, what do you want to do in a situation where you have too much vasoconstriction? Which part of the nervous system would you want to block? Okay, sympathetic. All right. And so let's take the sympathetic. So we have alpha and beta. Which one would you want to block here? You can have some alpha blockers if you want. They have that. What about there's some things too you can do a lot of times if you can control the heart rate. Remember, what is blood pressure? Heart rate times what? Equals blood pressure. So if I want to do anything to blood pressure, I'm going to have to mess with either the heart rate or the stroke volume. Well, it's hard to mess with stroke volume sometimes, so we can affect heart rate. And so if you wanted to look at a medication that affects heart rate, would you pick beta 1 or beta 2? Beta 1. There's beta 1 blockers, and there's lots of beta 1 blockers. So that's the kind of stuff. Not that we're going to give any, but when you see medications and people who have hypertension, a lot of times they'll take a beta blocker, a beta 1 blocker. Why is that important? Why do we need to know that? Well, if let's say you have somebody who takes a beta 1 blocker who's got a GI bleed, and you go to assess them, and they got a blood pressure that's in the tank, but their pulse rate's 70. They're taking beta 1 blocker. Beta 1's trying to activate, it can't because they take a beta blocker. So you got a guy with a GI bleed whose blood pressure is in the tank, and the body tries to help itself out and says, hey, speed the heart rate up because I need to circulate volume. I need to what? Increase what? I'm sorry, wrong side. I need to increase heart rate, but I need to also increase what? What part? The other one. Preload. Let's increase preload. So all of that comes through heart rate. I need to get that blood from the right side over here to the left side. So anyway, that's what we're talking about, physiology of hypertensive crisis. So we're talking about. So what can a hypertensive crisis lead to?
Stroke.
Okay, stroke is one. Dissecting aortic aneurysm. I like it. You know, aneurysms, that's exactly how they come about. Especially in the aorta, you know, large vessel here. Why? It's the same thing as your hose at the house. If there's too much pressure in the water hose, what's going to end up happening to the water hose? It's going to bust. I don't know if I told you, I first moved in my house I lived in now years ago. The pressure was too high at the spigot. And so I bought a hose, or the hose I had brought home, brought over there, busted. Damn, new hose. We got another hose, busted. I'm like, damn it, these hoses suck ass. Went back, bought like the industrial strength. I'm pissed off. I'm buying a hose that's going to last forever. Bust. And so now I'm like, okay, there must be something wrong. I did like that pressure coming out of there, to be honest with you, because it was good. But I ended up having to turn the pressure down at that spot. But the heart's the same way, the body's the same way. Once the aorta is under so much pressure, it starts ballooning out, right? And so therefore you get that.
Is there no medication? You said that anti-hypertensive medication that paramedics can give?
So years ago, we used to give Procardia in the field, and we could give it sublingual. And so they come in a capsule, and you would take a needle, pop the capsule, and squeeze that stuff, that Procardia, out of the capsule underneath the tongue. But very similar to nitro, it was lowering blood pressure so fast sublingually that it was increasing stroke. And so they said, you know what? Unless you're way out there, an hour away, it's best just to transport. Come on in. Because even at the hospital, we have to be really careful of how fast we bring that blood pressure down. So it's just the way it goes. But we cannot. I can't think of one that we get. I can't think of one of the as a paramedic would get right now. But it's important to know what the whole beta blocker thing in theory is, physiology is, so that you can recognize, okay, I got a patient who has a GI bleed, their blood pressure sucks, their heart rate's not coming up. First thing I think of in the field is what meds are they taking? Do they have a history of high blood pressure? Yeah, they do. Okay, what meds are they taking? Let me see them. Let me start looking at them. The other thing is, though, what else can uncontrolled hypertension lead to? It's pretty biggie.
Death.
MI, yeah. Death, it will, but
Essentially, right blood's
not so much blood clots. It's something that we covered here. Yes, but we said stroke.
Edema?
Edema. What kind of edema?
Metal edema?
What?
Pulmonary
edema. Very good, Alden. Pulmonary edema, right? And so, how do we get pulmonary edema? Well, it usually starts off with right-sided heart failure or left-sided heart failure, right? And we get that from uncontrolled hypertension leads. What do you have when you have high blood pressure? A lot of preload and a lot of afterload, right? A lot of preload, a lot of afterload, right? So what you're gonna have that afterload. You're gonna start throwing that plasma loose because of the velocity it's traveling, ends up in your lungs, go into your feet. And what do you see in your feet with that? Pitted edema, right? So which heart failure do we see pitted edema with right-sided or left-sided? It's always right-sided. And the reason why that is, I want you to think about it for just a second. Blood returns back to the right side of the heart, right? And so if we have right-sided heart failure, if the fluid can't make it back in, where does it go? Back down, right. And so that's why it's right-sided heart failure. Usually though, like I said, left-sided heart failures stems from right-sided heart failure. You always will get left-sided heart failure eventually from right-sided heart failure. So if you've got edema, you might be working on both, right? But if you'll see that test question probably on registry too. Pitted edema or edema in the feet, extremity edema comes from that right-sided heart failure. It does. So think about those things when you're thinking of uncontrolled hypertension. I can always just about nail it every time in the field when we get a call for difficulty in breathing. Get there, especially early morning. I don't know why, early morning calls, patient who's history of hypertension, usually non-compliant for about 3 or 4 months. Is usually about what it takes if you've got a real big high blood pressure history to end up developing heart failure. And it's just, and we have a lot of heart failure in this county. It's an epidemic of heart failure. So you will see it. That's why I scream at y'all about your treatment modality, about not giving albuterol Atrovent to your heart failure patient, right? Because yes, you're going to get bronchial dilation, but you're not going to get the bang for the buck because you're giving a lot of beta there, albuterol Atrovent, a lot of beta. And what's that going to do to your pulse rate? Sends it up. And when you send it up on a tired heart that's already overworked, you're right. It's going to start failing big time. And they get anxious really quick with that. And I call it the hypoxic fit. That's when they won't sit on the bed. They won't cooperate. You've lost it. Now, if you can't give narcotics, it's hard to get them back. So hold on your albuterol Atrovent for those patients, and let's put them on CPAP. Let's CPAP them. I will say something else too that you can do. I mentioned EMT school. Maybe I hope now that we've had a lot of it, you start to get the physiology part of it. Give them nitro. That's your patient you want to give nitro to that's hypertensive. They're going to be super usually hypertensive. A lot of preload, a lot of afterload. So we're talking 200 over 110, 200 over 140. This is not a hypertensive crisis, right? This is heart failure. Big difference. Hypertensive crisis, headache, dizzy, just generally don't feel well, nausea, right? Hypertensive crisis. This is I can't breathe. This is a respiratory, it looks like a respiratory illness, but it's not. It's cardiac. And what you can do is you can start dropping nitro. Earlier I said, how does nitro work? It's a what? A potent vasodilator. I love that word because this drug has saved more lives than any drug we carry in the drug box because it causes potent vasodilation. It means it dilates more than those coronary arteries. And it's going to dilate those arteries. It's going to dilate your lungs. It's going to expand the dead space so we can give that fluid somewhere to go. So pop you a couple of nitros and then get them on CPAP. And in the field, if I'm not mistaken, we carry Nitro Drips now for this. We have nitro paste. So instead of giving it sublingual, we can put it in the skin, let it soak in. Now, you say, well, can we do that in our scope of practice? Probably not technically doing the nitro paste, but you're going to be working with medics and you will be doing that. It's just part of, I'm just telling you, you're going to be doing that kind of stuff. What's that?
I think Pace is in the book too.
Yeah. And so you could drop some paste there. But give your nitro. And so this patient is having chest pain. That's what they're having chest pain and they need it. They need that nitro. It's going to save their life. Right? I'm not asking you to, if you ask them, they'll tell you their chest hurts. Their chest is going to hurt from breathing super fast and heavy and trying to live. That's a major call we run out there. It's a call that we can turn around, we can save. We really can, or we can help dig the grave. And I've watched so many dig the grave. So I don't want y'all to dig the grave. Don't dig the grave. Y'all can make this work and somebody can live another day. So I think that's it for that. I'm gonna try to put a video up tonight about the chapter. But that's, yeah, so we got to cover cardiogenic shock though. So I'm hoping the next scenario will be cardiogenic shock. I hope. Pretty pleased. If you can. If you can't, I don't care. If you really got one, you've been burning and you've been, then do it. But if it could involve cardiogenic shock, that would be great. All right. Thank y'all, but let's get another one in before we leave.
Everyone know what to do?
No. I'm sorry, increases the contraction. Heart rate is probably something.
What kind of drugs?
Yes, they can be beta blockers.
I was trying to sixes in.
You did, you just did. Very good.
My brain's dead.
Yes. It's just like that. It's a little more potent, and we got to be careful how we control it.
Is it still in like 100-liter bag?
Yeah, it's probably a 100 ml bag, and it's going to go on a medication pump.
Okay.
And so,
Act like I know what it is.
well, it's okay. You don't have to put it on that, but it's called a medication pump. It looks like a square box.
Oh, that's okay. I know what you're talking about.
And you put the IV tube through it,
I thought that was just a fancier monitor. Okay.
and that's what you do.
It's
And
the controls drip rate.
yeah,
Okay. Nice. Okay.
good stuff.